Okay. Always have to check. All right, we're going to get started. So we stopped here. We're going to quantify. We're going to describe it. That just came out pretty good. So we have some pictures here. Who wants to guess which one is granulation tissue? Yeah, correct. So nice and red. It's a small one, but it was really good. The tissue looked very good. Very red, bright red. If you can look a little bit, you see in here, I'll use this pointer because I want to try to be fancy. In here, it's like bumpy, right? That's healthy granulation tissue. This is epithelial tissue, right? There are a lot of times that, especially because it might be this color in someone who has darker skin. And so people may think that it's open, but epithelial tissue is smooth, a lot of times shiny, and then when you touch it, it's dry. So if it's smooth and it's light pink like that and it's shiny, it's probably epithelial tissue. Also, let me see, I might have some, okay. Look at this picture here. Okay, come on, relax. And you'll see that there's like hyperpigmentation, like dark spots, and then that pink spaces in between, that's epithelial tissue as well, okay? As you can see, this wound here that I'm on, there's some slough there. And that is like, that's kind of like Eschar, right? But looks like it started out as slough and it's like drying up. Then we have Eschar up here. And then this wound looks bone dry, okay? And hopefully I have a picture at the end. We're going to talk about what you guys think we should use on a particular wound. And then this is that clean, non-granular tissue that I was talking about. So the wound's clean, like, yeah, there's a little slough here, but this is not really healthy. It tells me that the wound healing is stalled. The shiny, slimy nature of it tells me that there's biofilm or lots of bacteria. And it tells me that it's stuck in the inflammatory phase. So we need to kind of like take care of this, right? Okay, so drainage. Important to describe and quantify the drainage. There was someone that came up to me on the break, and I will talk about the drainage that she asked me about. These are the ones I feel like are used most commonly, all right? So there's none. That one that's bone dry, nothing's coming out of there, it's dry. Serous sanguineous, right? So that's serous and bloody, a little pink color. Serous, just your clear, regular serous fluid, and bloody. Then you have purulent. It can be thick or thin. It can be a little bloody. It might be yellow. It might be tan. It might be green. It might be a little brownish. And it can come with or without odor, okay? Then there is drainage that's like a little, I hate to talk about wounds and related to food, but I do it so often. But then there's a type of drainage that's like milky, right? So it's like not thin like water, but not thick like milk, right? It's kind of white and or yellow, and that's the kind of drainage that you would probably get from this wound right here. So when you take the bandage off, it's probably going to be kind of milky, maybe a little slimy, right? But not quite pus, right? So that would be considered fibrinous, and I did not add that one. So where's the person that asked me about that? Thank you so much for coming up. I would use that fibrinous, and I use it often actually, because I see, especially when we're seeing the xylazine wounds, there's tons of slough. But I teach that to my patients a lot, like this is not pus, right? It's fibrin pieces that are coming from the necrotic tissue. Am I standing in anyone's way of seeing the slides? All right, maybe I am losing weight. Okay, so here's a sample wound assessment. So right forearm, full thickness traumatic ulcer, 7 centimeters by 3.5 centimeters by 0.5 centimeters. 40% clean non-granular, so that pink one at the bottom. 60% yellow slough. Peri-wound area macerated. Anybody want to tell me just right there, what's going on here? What's up with the dressing? Are we needing to change it or what? Right. The peri-wound area is macerated. That is telling me that whatever the person is using is not addressing the drainage appropriately. When wounds are in moisture balance, the peri-wound skin will be intact and it will be normal. Large amount of tan, thin, purulent exudate, no induration, erythema, or excess warmth. So we got to really intervene here. So we'll talk a little bit about identifying wound infection. For those of you who were there yesterday, I'm sorry. We're going to review it, right? Review. So you're going to diagnose it based on multiple signs and symptoms versus a single one. So versus just looking at one thing that said like it's draining or it's like got slough in it or whatever it is, you need to have multiple to make that. Don't do wound cultures. You don't need it. Don't do it. It's unnecessary for what we really need it for. That's like they're in the hospital and they're trying to figure out what antibiotics to pick. If you use antibiotics on something and the treatment doesn't work, then you might want to get a wound culture. But to be honest, punch biopsies are better than, the Levine technique? Is that what it's called, I think? Of, taking the swab back and forth. It's better. And then you might have more subtle signs in someone who has diabetes, arterial disease. And when I say more subtle signs, I mean, if you think about someone with autoimmune disease, their immune response is not as robust. So the things that you would look at for someone with cellulitis, really red, swollen, pain, lots of drainage. In someone who's maybe diabetic, it might just be like what we call a faint halo of erythema. Might just be a little bit more tender. Those signs and symptoms, those robust signs and symptoms are coming because of good blood flow. So they're not going to be there in someone whose blood flow is compromised. Might just be a little bit more subtle. I'm much more laxed with antibiotic prescriptions, oral antibiotic prescriptions for people who have diabetes or uncontrolled HIV or arterial disease than I am in some of the more young, healthy people who have really good, robust immune systems, okay? So here's our signs and symptoms of local infection, which several of the wounds on the other page had local infection. Slough, foul odor, purulent drainage, increase in wound size, increasing pain, and local erythema. And sometimes in a person who has, let me just go back, this wound,
I didn't touch it this time. It was you. It's like going to sleep.
Sometime in a person who has that wound, right, you'll look at it, and this happened to me, and like, all right, the slough is going, we got to figure out the bacteria. And they'll say, it hurts so bad, right? And the pain really is another sign to let you know that the bacteria are having their way, and we need to really intervene, okay? So pain is a really important one. And then local erythema that's less than 2 centimeters. And that one at the top with the eschar, as you can see, it was like really red around there. It's a very small amount of redness. So not really infection, but the body is reacting to that eschar. Like, we got to get there and get that out of there so we can protect ourselves again and close up, okay? And then this, topical antimicrobials, okay? Important. Silver, sustained release iodine, and I don't know if I put a lot of those dressings in there. I tried to do the more common ones, y'all, like the dressing thing. I could do a whole talk on just dressing selection alone. It's just a lot of stuff, okay? So I tried to give you the most common stuff and the stuff that's like, I feel like a little bit more easy for patients to use, easy for you all to use without a whole bunch of different training and understanding about like what type of dressing it is, et cetera, okay? Spreading infection, so that's your stuff like cellulitis. The satellite lesions or wound breakdown is really a big one. So like you're seeing somebody who has a wound, and then all of a sudden they come back in the next week or so, and the wound is just so much worse. And you're like, man, what is going on? But they're not really complaining about anything. And the wound bed itself doesn't look worse, but that's a big sign that something's kind of brewing. Okay, so you pay attention to that. And then fever, fatigue, all of those ones that are systemic. Anytime somebody has a wound and they're having systemic symptoms, that they need something. And sometimes, especially depending on what they're having, once you get to a person who's lethargic, they gotta go to the hospital. Send them to the hospital, okay? Because that's more than likely like sepsis happened there. Okay, y'all, This is a really important moment. This right here is the most important thing that I want you guys to remember. The most important principle for any wound, the treatment for every single wound is to treat the underlying cause. You are doing absolutely nothing if you're not addressing the underlying cause. Now, in injection, people are not going to completely stop injecting just because they have wound, but you need to be consistently addressing their injection drug use in relation to healing. Now, that's why it's important to set goals, because some people don't want their wound to close, right? But if they do, it's a conversation about, listen, you told me that you want this wound to close. We need to figure out what can we do to help you inject less in the wound in that area. I just had a conversation with somebody about helping folks find another location, okay? I've done that. Maybe here, so that they can give that area a rest. But you need to address the underlying cause, okay? So you need to correct or improve systemic factors that impact healing. Kara and I were talking about a patient that she had the other day. Person had terrible diabetes, has a wound. She's trying to convince this guy that the diabetes is having an impact on the wound healing. Through all of her miraculous care and talking to the person, they decided, you know what? I'm gonna start taking my medicine. She didn't really do anything fancy. The wound didn't look crazy. How long was it when he came back and the wound was drastically improved? From how many weeks of him taking his medicine?
It was like a month.
1 month. How long had he had the wound before?
Several months.
Several months he had the wound. He started taking care of his diabetes, and in 1 month, he had, I feel like it probably, just from the picture, maybe close to a 50% reduction in wound size. So important to treat people's underlying conditions. And then evidence-based topical therapy congruent with the wound healing goal. Meaning, if someone doesn't want the wound to heal, we are not necessarily pulling out all the stops. For what? We're going to give them something that's going to maintain the wound, keep them safe, and our goal in someone who is not looking for healing, whether this is an end of life, whether someone who's injecting, is to keep the wound as clean as possible and from preventing sepsis and underlying infection. That is our goal. So we're going to pick topical care based on those goals. Then we need it to be patient-centered. We needed to promote moist wound healing, okay? And we need to make sure that we're thinking about the skin surrounding it. If we're breaking down the tissue that's right on the outside of the wound, we're not going to get good epithelialization, which is the epithelial cells come from the edges of the wound, and they kind of like wave to each other like, hey, I see you over there. I'm coming. And they kind of just travel over the wound surface until they meet with each other. And then when an epithelial cell touches another epithelial cell, they say, oh, we did it. We're done. We're closed. Okay, perfect. So if you break down the tissue on the peri-wound area, you're going to be stalling that epithelialization process, okay? And moist wound healing is keeping the wound not too wet, not too dry. Perfect balance. Our bodies need to be moist, just like on the inside. All of our white blood cells and all of the other cells that we have in our body that are going to heal the wounds, they need to be at body temperature. They need moisture. They are not doing anything when they're not moist. Every time you take off a dressing, that's why I told you never do a dressing 4 times a day. Never do it. Every single time you remove a dressing, you are decreasing the cell activity in the wound that's pushing it towards closure. Every time, okay? We need to just let our bodies do its thing, and that's what we need to do. And then regular assessment of healing status so that you can change. Kara talked about this. Wounds are dynamic. You might start a wound care and then you have to change it. So you need to be assessing the healing so that you can adjust the wound care plan to the goals for healing. Step 1, we're going to clean. We're going to remove bacteria and non-viable tissue and any drainage that's on the side without causing additional damage. So 4 to 15 pounds per square inch of pressure, you can get that with some fancy wound cleansing devices and irrigation devices. But you also can get it with a 35 cc syringe and like a 19 gauge, like needle, or you don't need a needle. Come on, what's the things you use in the hospital? Angiocath, thank you so much. A 19-gauge angiocath, and you can use that. That's a great pressure to kind of help loosen things up. Put your goggles on, PPE, all right? It's gonna splash a little bit. That's a good pressure. And then the peri-wound skin needs to be cleansed. If there's bacteria out there, it's just gonna come right on back into the wound. So you need to spend time cleaning that as well. And then your cleaning agent is gonna depend on the status of the wound. If it's clean, like that granulation one, you're just kind of doing a gentle flush. That would be a great one to see in the cold. You don't need to have them take their pants off. You can just drip a little water on there and their socks don't get wet. So that's a great one. And then hand hygiene and clean wound technique are really important. I think that I'm gonna maybe demonstrate like how, anybody feel like it would be helpful to see how I'm like changing the wound, like cleaning it? Yeah. All right, cool. I'm gonna get an assistant. Hillary, come on up. Hillary, I'm gonna have you stand right here. And then I'm gonna grab some stuff. Bear with me.
Anyone want to sing? Anyone want to do anything? Who's got a talent? Anyone know any good jokes? Kate got us these really cool wound models that we got to look online and find the ones that look real gnarly.
We're the real deal.
Look at this one. This is like a good xylazine looking one.
Yeah, hold it there. Okay. We're gonna do some pretending. Okay, visual imagery.
Do you want me to hold the microphone by your ear?
Oh yeah, thank
Okay.
you.
I feel like I want to participate. This is cool. All right.
Fancy. Okay, so we're pretending that. Oh yeah, can we do that without messing up the video? Oh yes, let there be light. Good afternoon. All right, so I'm pretending that this person has a wound dressing on, right? I'm also pretending I have sanitizer. So I see this person, they have a dressing, I have sanitizer. I put too much, I'm taking a long time. Okay, don't do this, but. So I'm gonna put on some new gloves. I'm gonna come over here. I'm going to take the dressing off. I'm going to take the dressing off. Usually for me, depending on what the dressing is, I like crumple it up in my hand, fold it in the gloves. This is the trash. Sorry, y'all. I'm not trying to disrespect your stuff. All right, that's trash. Time to clean. Sanitize. My hands are dry. I'm going to put new gloves on. I have my stuff sitting here, right? I have my goggles because I'm going to try to irrigate it. And I'm gonna right? In a wound when you're using a gauze, really important. You start in the center of the wound and you wipe out. Once you hit the skin on the outside, this is done, dirty, done. You start in the center, circular motion, done, okay? Until you clean the whole wound. Now it's nice and fresh and clean. All right, I forgot my dressing.
Getting a good, like, isometric hold on that shoulder.
Okay, now, hands dry, new set of gloves. Dressing. We're gonna save this. Right? Don't want to waste the foams. And then I'm gonna cover it. And then this foam doesn't have an adhesive border, so I would probably put like a roll gauze over top of it. I also would not use this. This is a bad choice of size. Doesn't cover the whole wound. So I would have probably put 1.5. I would have put this piece up here and another one. And then I would have wrapped with gauze, okay? I don't use Cohen, but you guys do what you feel is best, okay? That's, how many gloves did I use? 3? So at minimum, 3 sets of gloves. Don't y'all go out there with one pair. I'm watching all y'all, okay? Watching y'all. Yeah, go ahead.
Okay, so did you just, these are really like just a little minor. detailed questions. Did you wet your gauze, or did you just use the dry gauze? And then the second one is, did you put any of the antibacterial ointment on that? Or
So-
should we?
I irrigated the wound.
Yep.
It was irrigated. And so since I irrigated, what I was doing was just trying to remove and to get any additional like drainage that was laying there, and possibly this one doesn't have like slough in there. But if the irrigation helped to loosen up some slough, it was to kind of remove that from the wound bed, right? So I took the gauze that was wet. I did wet it with saline.
Okay.
We're visualizing that. And then I put that on the wound with whatever cleansing solution. I usually don't use different ones. So if I'm irrigating with Vash, then I'm using Vash on the gauze to like wipe as well.
Okay.
And then what was your second question?
Oh, if that would be a good wound to just use the local antibiotic ointment on that foam, would you put that on it?
So
or?
generally, if I'm using a foam, that means that the wound is draining a lot. So then I wouldn't add something else that's moist to the wound. And if I'm using a foam and the wound is dirty, where I feel like it needs some type of antimicrobial coverage, I'm going to use something that is in the foam, if this is the primary dressing. Primary meaning like in contact with the wound. So I would maybe use, if I'm worried about bacteria, instead of ointment, antibiotic ointment, I would use a silver foam, or a foam that has sustained release iodine. And then you don't need to add an ointment. I am not a big proponent of using lots of different supplies together. There are some supplies that if you use them together, they counteract. One in particular we'll talk about when we talk about dressing supplies. So, and also in this population, I'm trying to keep it simple. I have found that when I give somebody an ointment to put on, they just put this on. That's it. They don't put the ointment on.
Okay.
I'm sorry. I just wanted to point out, I do the supply ordering. Just so you know, if you guys are not able to get this covered under the insurance, the silver is wildly expensive if you're buying it yourself. So, see if you can get it covered by the insurance. And then the second thing is how Lyd did the gloves. The reason we wanted to add this part is because when we're talking about all the pop-up wound sites, the volunteers that are out there are not being trained to change the gloves. So you will just see they'll do like 6 different wounds with one pair of gloves, and you're like, oh. So if you are having people go out, please assume that they don't know clean technique and that they don't know. And I mean, I'm talking about any clinical. I don't care. Like doctors, nurses, don't assume that anyone knows how to change a wound in the community, and please express the importance of hand hygiene and changing your gloves.
Could you quickly comment on Adaptic or Vaseline impregnated gauze and the use of those products on these?
So we're going to talk about dressing selection. I think there's a place for those dressings for sure. In regards to Vaseline impregnated gauze, I don't use them a ton because, like I said, a lot of the wounds that I'm seeing currently have so much bacteria in them, they need some substance that's going to address the bacterial load. What did you ask me about? Adaptic as well? I like Adaptic to use specifically if a wound is very painful for me to change. I might use that as an interface between this foam. What did I do with it? Hand it to me. I'm going to pass it around to you. This is a silicone-backed foam, and so I'm going to let you feel it, and I'll show you. It's a little tacky, but not painful to remove. So I'm going to pass this around so everyone can kind of feel that tacky feeling. But I will use Adaptic in an instance when I don't have maybe a silicone, or I'm using a dressing that maybe works well, but hurts to remove. Adaptic is great to use if you're doing a wound vac and you want to protect, as a contact layer, if you want to protect underlying structures like tendon, bone, etc. But I don't generally go for those Vaseline gauze and Adaptic regularly, and that's not because I feel like, this is Adaptic for other people. That's the brand name. I try, y'all, not to use the brand names because if you remember what type of dressing it is, then when you see something else, you'll know what the use will be very similar, so you'll know what to use it for. So non-adherent oil emulsion gauze is what it's called. I'll use that. I see another hand. So it depends. I feel like a lot of our folks, if they're coming in for wound care, they usually use before they come in. And so that's their pain control. I'm going to be honest with you. I have been told that I am not the most gentle. When I clean wounds, that's what they have said. And I'm probably not.
Call you.
One of my patients calls me Tyson. So they usually use before, but like when I worked in home care and I had someone whose wound was really like painful, I would advise them. I would tell them when I'm coming in home care, you give people a window. I'll be there from 10 to 2. And then I might call them 30 minutes before and say, hey, go ahead and take your pain medicine, take your ibuprofen, or whatever they have prescribed for pain. I will take that. I don't usually like I feel like in some wound care centers, they might put like a lidocaine or something on the wound. I don't usually do that. I mean, I'm just going to clean it off. I don't know. I don't do it. I'm not saying it's wrong. I just don't usually do that.
I think this is also like something where for our folks who are very like traumatized by having the wounds cleansed by other people, this is a really great opportunity to involve people in their plan of care and like have them cleanse the wound, and then they can do the pressure that they feel comfortable with.
I
like
do
if
that a
it's
lot.
so, I mean, you know, a lot of times people are like me, like I take off the dressing, and we just kind of like coach them through it.
Yeah.
And that is fine.
A lot of my patients do that. No, you too rough. I'll take it. I'll do it. Give it to me. Give me. Yeah.
Oh, sorry, really quick question. Kara, do you order, or you're the supply orderer? Yeah.
She's a lot of things.
No, it's okay, I get it. Are you using McKesson primarily? Are you using are you using like Nason? Are you using?
For our stock, yeah.
Yeah.
Yeah, so the question is, where do we order our supplies from? We order our stock supplies from McKesson for the most part, and then we have like local DME supply companies for like if we're. So like I don't order a lot of like our stock stuff with silver. I have like a very like. We have a few things of that. And then like I'll have a lot more like plain foam that we'll do for like a day or two. And then because so many of our folks are insured and their stuff's covered by the insurance, then we'll order through like a DME company, like Bright is a local one for us. And then we do that. But yeah, McKesson for the stuff.
When you guys are seeing, I'm sorry, a lot of the wounds that I mean, I think maybe this is true for a lot of people, but we're seeing a lot of wounds with a lot of slough, and then and they're very moist inside, but then on the outside is very dry, right?
Mm-hmm.
Like, are you putting any kind of like barrier ointment on there?
Mm-hmm.
Do you do ABG, or what do you recommend?
It depends on how broken the skin is, right? So around you can have a fungal infection. I feel like people who have venous ulcers, notoriously, if you're doing layered compression, can sometimes develop, especially in the summer, like a fungal infection around it. So I will treat that, right? So I will use an antifungal. Or also in venous disease, they have a lot of stasis dermatitis, so the wounds drain so much. And the drainage and the makeup of the drainage is really caustic to their skin. So then they'll talk about how their skin is burning or itching, right? I will use, on intact skin, I will use a steroid cream. And if it's dry, I may use amlactin, right? And the venous, they're good. You get all the skincare stuff you're going to be doing around someone who has a venous ulcer. Their skin is like a mess. So I do like amlactin if it's like dry and flaky. I might put some A&D ointment, especially if whatever I'm using might possibly get onto the skin to kind of protect the surrounding skin, as well as to give it a little bit moisture. If it's super dry, I usually recommend using a thinner lotion-based cream-based treatment, because as we know, our skin ointments hold in the moisture, right? Creams soak into the skin, and lotions are able to soak into the skin. So if you're putting an ointment over skin that's already dry, the lotion and then the ointment is a little bit better. Yeah.
I have the luxury of like being a doc, so I can do a little more like treatment.
Yeah.
Things. Like what have you found for like those really fibrinous, kind of like stuck on exudate ones? Like what's the best technique that you guys are doing to kind of get those as clean as possible?
So we will do sometimes like conservative sharp debridement. We're not doing sharp debridement traditionally out in the field, but you know, that little jiggly stuff that's kind of like almost off, we're just gonna snip it off, you know, we'll do that. Kara had a patient last week who had like It was almost like, I don't even know, it was crazy. But like looked like almost like a sheet of like thin rock over top of his arm. It was so hard. So she kind of like, lifted that up and kind of used some instruments to kind of remove that. So we're doing that. But the majority of our debridement techniques we're using the dressings. So we're doing a lot of autolytic debridement with the dressings because of the environment. Also, like I said, we're usually in pretty like dangerous environments, so we don't like to carry a whole bunch of like sharps around and have to worry about disposing of them. So we're doing mostly autolytic debridement, which is slower sometimes. But also these folks are relatively young, so to be honest, it's really great. It works great.
And then we do, like, if you're trying to get something to penetrate, you can, like, score the eschar with, like, a scalpel. So
Yes.
that's, like, a good way to kind of get it to penetrate. And then, again, just if you have a team with people who are, like, learners and stuff like that, this is not where they should be learning. They should not be learning how to debride wounds in the street. It's not best practice. They should not really be like debriding things with like scalpels. It's not best practice. So
Not in the field.
not in the field. So just to keep that in mind about like err on the side of being conservative, but you can also score stuff to get it to like the guy's thing. That was what I did. I could take off as much as possible, and the rest was like, it was almost like cowhide. It was just like black eschar and just dead, and we scored it. So I'll see how it is on Friday when I go see him again.
Also, I just looked at a different product. It's called Debrisoft, and it's supposed to be like it looks almost like a gauze pad, really. But the way the makeup of the pad is supposed to be a way to like, looks like they have gauze, and they also have like lollipops where you can use it to debride like slough and biofilm, and to kind of like push. Every time you debride a wound, you put it back into, and it starts bleeding, it goes kind of like back in that hemostasis phase, and so it can restart the healing cascade and kind of like slowly push it out of the inflammatory phase. So I've been looking into possibly using that as a way that also can help to facilitate removal of biofilm, specifically for our folks who are using xylazine and have chronic wounds, as well as just a way to kind of see how it works to more quickly remove slough, to kind of push these people to closure more quickly.
Has anyone used Debrisoft? Because we are, a little FQHC with limited funding, and we're waiting till our spend down starts in the end of the fiscal year. Where I'm like, spend down. So we're gonna buy it next month. But has anyone used Debrisoft in like the hospital or something? Can comment on it?
Yeah, we found out about it from our fancy friends over at Jefferson.
Yeah, all those hospital folks have
Lots
so much
of money.
But we're in spend down mode, so we'll let you know the next time.
Yeah. So one more, and then I'm gonna move on. I'm gonna talk about that coming up. Hang tight. So clean wounds, we're doing gentle flushing. Those wounds that are granulation mode, cleaning, gentle. We don't want to damage the granulation tissue. It's not a lot of slough, not a lot of drainage. If it's granulating, it has started to move past the inflammatory phase, so we just want to protect it and do moist wound healing till closure. If it's necrotic or it's infected or it looks like that wound that has biofilm, we're wanting to use some pressure to really kind of disrupt the biofilm, lift the slough, loosen things up so that we can clean it. I love Vash. It's hypochlorous acid. The insurance in our area does not cover it, which is, I'm just sick of them. But I love it. It's non-cytotoxic, and it really, every time you use it, it kills biofilm. Yeah.
Just kind of a logistics question. It seems like you prescribe a lot of things for patients, but a lot of times I'm assessing a new wound and treating it at the same time. So like, how logistically do you manage to like get the materials for that person?
So we do keep a good stock of supplies. So we usually carry Vash. We order foam. We order calcium alginate. We order some of those specialty supplies, and I use that. But if I don't have it, I just use what I have. And I give them the best option of what I have, and then I order the supplies. Yeah. It's okay to use what you have. You can, like we talked about, that one time if you don't have, you're like, oh man, I don't have it. It's cool. What you're gonna do in the interim, it'll be okay until you get what you need. Yeah. All right. Okay, let's move on. So, debridement. Here we are right there with that Santal question. We're coming. Eschar and slough impede wound healing. They gotta go, okay? Eschar and slough are dead, so that means that there's lots of bacteria clinging to them. So we need to get them out of there to, well, this says they increase the risk of infection, so we need to remove them to decrease the risk of infection. And they also cause odor, right? So we want to get them out of there so we can, I feel like the odor is a super distressing thing for patients. So like we want to do that to try to get the odor decreased. And then so here is when debridement is contraindicated, right? In an contraindicated in uninfected wounds that are poorly perfused. So if you have a patient who has very limited arterial supply, I'm thinking about like a foot, right? There's a wound there, and you know this person has peripheral arterial disease. And they have a stable, firm eschar piece over top of the wound. It's not draining, right? Generally, unless you're going to get that person some better perfusion, leave it be. Okay? People who have arterial disease, 911 vascular, they are not going to heal. We got to figure out some way, might not be surgery, any possible way that we can increase some perfusion. I usually try to get them on board. And then in the heel of an immobile patient, so a bedbound patient who has a dry eschar cap on the heel, you don't debride that, leave it alone. And I had a patient who had, like eschar, she actually had a heel pressure ulcer, and she also had peripheral arterial disease. This was a while ago. And then over time, it did fall off. It took a long time. And then in those instances, if it's eschar and you're not going to debride it, that's when I would use betadine swabs, and you swab it once a day to decrease the bacteria on the surface and to also keep it dry. Because once it starts getting moist, then you have to debride it. If it's dry, if it's stable, like you can't move it around, there's no surrounding like wound, there's no drainage, leave it be. And so the method of debridement is going to depend on the amount of dead tissue, whether the wound is infected, and the patient's wound goals, right? So like I said, if someone's really saying, I'm going to continue to inject in this wound all the time, you may not saying you wouldn't, you may not necessarily pick a more expensive type of debriding agent, maybe like Santal, for someone who's just going to kind of keep injecting in the wound, possibly. So you just need to think about those things when you're picking a regimen. So autolytic debridement is our body's own debriding system. So our white blood cells and naturally occurring enzymes digest necrotic tissue, and it occurs naturally when the wound is moist. That's why moist wound healing is so important. The wound is dry, your body's doing nothing. So if it's moist and it's got enough moisture, if it's closed and it's got enough moisture, your body automatically is going to do the autolytic debridement. Once again, in my patient population, most of them are pretty young and healthy, so they have they have relatively robust immune systems, and compared to someone who's maybe in their 70s, who's got long-standing diabetes or high blood pressure, etc. As you age, of course, your immune function declines. So I like autolytic debridement. It does not damage the healthy tissue because it's selective. Your body only debrides things that need to be removed. It's going to usually cause, this is really important, it's going to cause increased drainage initially. So it's important to protect the peri-wound skin, and it's really important to let your patient know. There's so many times that a patient will say, yeah, I used to use Meta-Honey, but it made the wound drain too much. And it's supposed to do that, especially in the beginning. It will taper off. Once it kind of comes in and really kind of stabilizes things, it does taper off, okay? So you can use things like medical grade honey. Everybody knows about Meta-Honey, but there are other brands that have medical grade Manuka honey. It comes in various formulations, in a gel, and an alginate. I think I might have some Meta-Honey alginate if we can look through those bags in the one that I brought, and I'll pass that around. So it has the Meta-Honey in it that's going to help with debridement, but it also has calcium alginate in there, which is used to absorb drainage, right? So you get a little bit more bang for your buck. Then we have hydrocolloids, right? So I'll pass them around too. What's that? That's wound gel? Yeah, pass them around. Hydrogels, right? They can come, there's a tube coming around. It can come in a gel tube as gel. It can come in a sheet. It can come in an impregnated gauze. Hydrocolloids are usually, they're either bordered or not bordered with like a transparent, like Tegaderm, like siding, or they might not have a border. And then any other item you use, like even if it's just antibiotic ointment, non-adherent gauze, and ABD pad, if it's keeping the wound moist, not too moist, it is doing autolytic debridement. So anytime you put a dressing on a person and it's helping to keep the wound moist, your body is doing this naturally, okay? The dressings just increase the body's ability. Like Meta-Honey in particular has a very high osmolality, so it pulls fluid into the wound bed that has white blood cells and other things to help make it a little bit more of a robust response, which is why generally with Meta-Honey in the beginning you get lots more drainage, and that's pretty normal. Then enzymatic debridement, here's Santal. Santal's been around for a while. It is the only enzymatic debridement currently on the market. I feel like before I was a nurse, there was something called Panafil, and Panafil was so great. It was papain urea, which is like in papaya. And it used to, when I say it used to get in there and do its thing, okay, it used to eat that stuff up in like a matter of days. Y'all know how Santal is. You're going to put it in that wound. It's going to be like watching paint dry, child. So Santal's the only one on the market. It's ointment-based, not ointment bases. It breaks down denatured collagen in the wound bed, okay? So it's collagenase, so it breaks down collagen, okay? It doesn't harm the healthy tissue in the wound, but it can possibly irritate the surrounding tissue, so you don't want to just like be all willy-nilly putting it all over. Also, it's really expensive, so don't waste it. I
just want to tell you guys something real dumb, just because this is like a dumb insurance thing. Santal in Pennsylvania, it costs about $200 for like a little tiny tube. It is 100% covered by insurance. Meta-Honey costs about, for that little tube I'm passing around, maybe that's like $10. For a bigger size tube, like a toothpaste tube, it's $30. It is not covered by insurance. Ha 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 ha. So you can order this $200 thing.
That doesn't work that well.
Doesn't work that well. You'd have to buy Meta-Honey. That's why we give away those little ones. And then the Triad paste, which I think is the one that I had not heard of until like 2 years ago when Lyd brought it up, and now we use it a lot. That is covered by insurance. And that is about the same price as Meta-Honey, but you can get it covered by insurance through DME.
And the Triad is working on autolytic debridement. There's also zinc in it, so that helps to decrease the bacteria in the wound bed, okay? Santal is something that I don't use often unless I have someone who is poorly perfused. So that would mean that I know that their white blood cell and their immune response is going to be blunted. I might decide to use Santal, but being completely honest with you all, I don't generally prescribe it. It is not something that I use. It works super duper slow, and I find even in those folks who have poor perfusion, the autolytic debriding agents that help to kind of support your body's own process work a whole lot better. Then we have chemical debridement with Dakin solution, 0.0125%. That's Didaxol is the brand name of it. Or if you work somewhere where you have a pharmacy, like they can make it at like a compound pharmacy or something like that. I used to have like a formula for like how to make it with regular bleach, but I feel like, I don't know about y'all, I cannot find any bleach that's not like double concentrated. So then you got to figure out, you know, depending on what kind of bleach it is, what the formulation is. The Didaxol is probably maybe about $20, but the bottle's much bigger. So I do use this. I love to use Dakin's for chemical debridement if there's a wound that is super funky, okay? My go-to is Dakin's. If it's smelly, I'm using Dakin's for 7 to 10 days to help to decrease the odor. And also the Dakin's kind of helps to loosen up the attachments between the slough slowly to help it remove. Now, a lot of the evidence will tell you that you shouldn't really use Dakin's. There's a lot of other good options, but at the end of the day, we are working in settings where we have limited resources, and I'm here to tell you that Dakin's is still a very good, viable option to use if you have a funky wound on the brink of infection and has lots of slough. 7 to 10 days or less. Usually after about 10 days, you can start to get from the long-term use some damage to the cells, so which is why you keep it kind of short. Maybe up to 14 days you might go, but usually I limit it to about 7 to 10 days. It's kind of just like smash the bacteria over the head and calm it down, and then we may transition to something else. And then you need to protect the peri-wound skin. It's bleach, so I might use a betadine swab stick to protect it. I might use A&D. I might use, which I love, like no sting skin preps around the edge of the skin to protect the deacons. Yeah.
You were talking about the Santal. Did you talk about like what to put on top of it or what not to put on top of it? Thank you.
Thank you. So Santal, I'm like skipping around, y'all. I'm sorry. It's cool. So Santal, I don't think I wrote it on here, but I might have wrote it later down the line. You need to use a moist dressing over top, okay? If the wound is wet, super wet, you can use like, whatever, like sometimes if the wound is super wet and you're using Santal, I might use a calcium alginate because calcium alginates, when you put them in the wound, a lot of them gel up, so they're going to maintain that moisture balance. If the wound is dry, you're going to need to add an adaptic, which I feel like doesn't add that much moisture, a hydrogel, even a saline moist gauze. If you don't add that moisture, it does decrease the effectiveness of the collagenase enzyme, as well as it can desiccate or dry out the wound bed. Okay, so really important. Thanks, buddy. I think I got that coming. Also, I'm going to just say it here too. You cannot use Santal with any other product that contains a heavy metal. Silver, bismuth, zinc. I have been seeing a lot of folks doing Santal in Xeroform. The yellow in the Xeroform is bismuth. When you are doing that, you are using $250 Vaseline on the wound. It completely deactivates the collagenase. Don't do that, okay? So you really need to pay attention to what the dressings contain so you can make sure that there isn't a reaction. You cannot use Santal with any dressing that contains heavy metal. Yes? Yeah.
They'll get discharged, not show up for wound care for a week or two, and then come with this like poorly adhered, ridiculously painful, wet to dry dressing that's been dry for 2 weeks.
Mm-hmm.
And then they're totally turned off from using Dakins again. So how are you getting people to follow up that regularly? Are you seeing your patients every day when they're coming back for this, or how do you get people to like Dakins again?
So I feel like I use Dakins in my current care in specific circumstances, usually when the wound is funky. Otherwise, I use other options. We do primary care and medication for opioid use disorder, so we prescribe folks a lot of Suboxone. We have our patients generally who are like not really stable and who are continuing to use and struggling to take their Suboxone. They're coming in every 1 to 2 weeks. So I'm checking in with them regularly, and then a lot of times we see in the same people in the office as well as out on the street. So I can also check in on them that way. But I feel like a lot of my folks, when it comes to like wound stuff, unless it's like a severe infection, they don't go to the hospital. And they come to me first. And then if I say, you need to go to the hospital, they'll go. And then when they come out, sometimes I'll say like, well, what were they doing in there? And they're like, I don't know. I'm coming to see what you're telling me to do. I'm not doing what they say. So they will usually come to me after discharge and say, like, I got this wound. What should I be putting on it? So then we can have a conversation about it, too, whether I think they should continue Dakins. But I haven't had too many folks, the people I am using it on, have, like, complaints about, like, not wanting to use it. Yeah. All right, y'all. Have safe travel. Okay, here we are, the fun part. This is the part everyone came for. So dressings don't heal wounds. They support wound healing. They are not solely responsible for wound healing, okay? Based on the findings from the wound history and assessment is going to drive what dressing you're using, okay? Deep tunneling wounds need a dressing to fill dead space and then likely another one over top as a secondary dressing. Very rarely you're going to find one dressing that you can pack with and then it can also be used on top. Some foams, but mostly you need a secondary dressing. Dry and low exudating wounds need dressings to donate moisture to the wound bed because we need to keep that moisture balance. And then moderate or heavy exudating wounds need a dressing to absorb moisture but not dry it out. So we need to maintain that moisture balance, and we need to consider the need for peri-wound protection. So like if someone's got really fragile, tender skin on the peri-wound area but it's draining a whole lot and it's like irritant contact dermatitis from the drainage, I might opt to use a silicone foam that I passed around that's kind of like really painless to remove from the skin versus something that might be a little bit more sticky, okay? All right, so gauze, here we have categories. I have like this here that has like a little bit more information, and then I have a couple slides that I tried to give y'all some one-pagers. So stuff is like squeeze on it, put your glasses on, so that you have something to kind of like have to look at to figure out like different categories and like the important things to know about it. But we're going to go through these separately. And so gauze, woven, non-woven, right? With or without antimicrobial. So the major antimicrobial in gauze, I feel like is, and I cannot remember what the real, I guess, what's the name called? The chemical name. But PHMB is sometimes in gauze dressings, and that helps to decrease bacteria and help to clean the wound. It's non-cytotoxic to the wound. So sometimes you'll see gauze that has that in there. And so woven, you should be using that more as a secondary dressing, and then the non-woven ones, a lot of times you can use as a primary dressing. The woven ones, sometimes if you're using them on the inside, if it's non-woven, you just want to make sure there isn't latex in there, right? You can, sometimes depending on if you need to cut it, like those little fibers, gauze fibers could kind of get stuck. So they usually recommend using the non-woven as a primary dressing. Hydrogels, which I passed around, donate moisture. Shallow or deep wounds, but if you use it in a deep wound, you probably would need to use like a hydrogel impregnated gauze so that you can get in those areas. And then the frequency of change for lots of dressings will depend, depends slightly on how it's manufactured. So those package inserts, they have lots of good info in there. Check them out. Then hydrocolloids, did I have any? Good. They're made of gelatin, pectin, and cellulose gum. And they react with exudate to form a gel over top of the wound to keep it moist. And they may have that odor, so that's why you need to assess the odor after it's cleansed. They can be semi-occlusive, right? So there's occlusive means no air can get in or out. And semi-occlusive means there is some air that's able to move through. That's important because if a wound is infected, and you were to likely, like Kara's patient, somebody gave that person a hydrocolloid, and then she came back and it was like a gaping wound. It's just a petri dish. You're creating a petri dish, and the bacteria just go like, yes, we're in here, and nothing can get us, and they just tear things up, okay? Impregnated gauze, so that's your bismuth, which is xeroform, petroleum gauze, petrolatum. There's zinc-based impregnated gauze. Iodine impregnated gauze, so that's iodoform is like one of the common ones that we use, which I do use sometimes but very short term because the iodine that's in iodoform is cytotoxic, okay? Alginates, which are polysaccharide fibers, they're derived from seaweed, which is important when we compare them to hydrofibers. And so some of them gel while others like wick moisture, right? And they usually come off really easy. You don't put them over bone, tendon, etc. So this would be in a situation where someone's got bone in the wound. I want to use an alginate to absorb moisture. I want to still protect the tendon. I may put Adaptic if I don't have it. But there's really some other better options for contact layers that don't add that moisture that kind of are easily removed. So I would use a contact layer to protect the tendon, and then I would pack my wound with the alginate, okay? Cellulose gel is what makes up hydrofibers. This is important because hydrofibers, the biggest brand everyone knows is Aquacel, right? Aquacel is not a alginate, which is why if you ever, I don't have it because I don't really like it, I don't use it like that, but they have little like woven strings in there. And that's important because if you're going to cut it, you can't cut through the strings. You have to cut in the direction that the strings run, because if the hydrofibers are left in the wound bed, that's like a foreign material. So they can have issues from that. The alginates are derived from seaweed, so they naturally dissolve in the body, which is why you'll pull an alginate out. Sometimes it'll be like, you put a long piece in and it kind of like shrunk up. That's cool. Some of it absorbed into the body, and also when it gels up, it shrinks too. Not hydrofibers. So do not cut Aquacel or any dressing that has like stitching in it against the grain of the stitching, because it's there for a reason, okay? Then we have foams. They're polyurethane, small open cells that absorb the drainage. There are some multiple shapes and sizes. You might see some that are shaped in like, a finger, or like the sacrum, or oval, all of these different shapes. They have borders. Some are without borders. I usually prefer to order dressings that come without a border, because I can then make it whatever size I want, versus if you have a dressing that has a border, you can't really put it on you can't put the sticky part on an open area. So I prefer using non-bordered foams. They can have silver, etc. in them, or iodine or other substances. All right, y'all still hanging in there? All right. So here's, oh man. All right, so here's like a one-pager with like the major ones here that has like most of the quick information, so you can kind of look at it and be able to kind of know some of the most important information about it. We went through a lot of the other stuff, right? So I wanted to create something that you guys could like have and print out. We did have some, Lizzie created like a one-pager for y'all too, which was great. And then there was another one, this one here. What's this one called? That was in like an article or something. And I just want to call y'all attention to the last page up here, at the top, the very last one on the right, where it says wound care experts use Vash solution, which I was like, all right, come on now. Xeroform gauze and Mepilex. Now, I don't know if they're talking about they use Xeroform and then they also use Mepilex, but I want to clarify. You don't need to use Xeroform and Mepilex. It's counterproductive. The wound is too wet, right? So why are we putting ointment on there? Okay, but I have seen people doing both together. I'm not sure what they're going for, because the Mepilex is also not a good autolytic debriding situation. The bismuth will help decrease bacteria, but then I'm like, well, why aren't they using a silver foam? Confusing. Don't do that. Also, you want to kind of keep it simple, so don't do that. Here's the information about the alginates, the hydrofibers, and the foams. And we're going to add the slides, so don't worry. You don't have to use up all your phone memory. Taking photos. I got you. And then Triad is an autolytic debriding agent, because it's zinc-based, it's paste-based. It helps to create moisture in the wound. And there's some other things in there that kind of help to decrease the fibrin bonds between slough. And if you can see here, I put on each one of these like the days that you can use it. So hydrogels, generally you're going to change every day, unless the package insert tells you it can stay longer. But also you're the provider, the clinician, and you need to assess how long they say it lasts is what it really lasts for your patient. So even if it says it can stay on there for 7 days, if you come back in 7 days and it doesn't look like it still was there, then you need to change it more frequently. And then, so I put the amount of days that you have usually. I very rarely have I had a hydrocolloid in for 7 days. They just kind of, once you start washing up, rolling around, friction, they come off. One quick thing about hydrocolloids, if you're putting a hydrocolloid on somebody, I feel like in pressure ulcers, they're used a lot more frequently than like xylazine, etc. If you're using a hydrocolloid and you put it on and it doesn't stay on there for 3 days, it's the wrong treatment. Don't use it again. If you're putting it on there and it's coming off every day, don't do that. It's tearing the skin up. It's not staying on there the way it needs to. I find that a lot of people using it for pressure ulcers in the sacrum, the person's incontinent, the thing is coming off every day. Wrong treatment. I don't think I put pressure ulcers in here, but that might be something that you would use. Like I love for sacral that's not super deep. I love zinc-based paste, so I probably would use a Triad, or even like, butt paste, or like Desitin, those things sometimes work a little bit better for the care. Remember, the dressing is not what's important. So for a pressure ulcer, can anybody guess what the number one treatment is? Exactly. Y'all got it. Remove the pressure. So I will use that sometimes because that's something that can be easily reapplied if the person is incontinent, and it can also protect the wound, especially if it's superficial, and really focus on removing the pressure. All right, so I have these here for y'all. We talked about the Santal. Yes, here it is. Not compatible with those heavy metals. Don't do it. Oh, this is important too. Okay, good. So 2 millimeters thickness. So you can't just put a little glaze on the wound with Santal either. And I know y'all have seen the tube. The tube is small, okay? You need to put a nice thick layer on there because if you don't, that's when it also can dry out. So you need to put a nice thick layer on there, like a nickel like size width of the dressing of the Santal on there, okay? Where are we? Oh, yes, test time. All right, so who wants to try to, with all we learn, I know it's a lot, there's no wrong answers here. Also, wound care is not one size fits all. There's more than one way to skin a cat. Just because I wouldn't necessarily do it doesn't mean it's wrong, okay? Anybody want to take a stab at what they think would be a good dressing? Anybody? Don't make me call y'all names, call y'all out. I don't know y'all names, but I might pick y'all. Somebody try. Go ahead.
I am not really sure, but it looks like there could be some undermining there.
Come on now,
so,
come on now.
Yeah, probably some maybe just moist gauze. Into
You
that
could do
area.
moist gauze, okay. Anything else you think?
Yeah, it looks a little sloughy, probably exudative. So some kind, maybe a foam. It doesn't look obviously infected. So
Okay, so you're gonna pack it with gauze and cover with foam. Cool. Anybody else? And so you're gonna get debridement of the slough by autolysis, right? You're gonna either try to remove it or remove it, or you're gonna just, and whatever's left, you're gonna let the moisture kind of have the bodies do its thing. Okay. Anyone else? Come on, y'all, don't be scared.
Actually, this is a question I want to ask because now if no one knows what to do with this wound, what are you going to do with the wound? Right?
Oh yeah.
If no one, for the people that don't know what to do with the wound, what are you going to do with the wound until you figure out what to do with it? What is the no harm dressing that we talked about yesterday and today?
Yeah, so you can cover it. Even if, of course, it would be preferable to pack the dead space, but if you don't know what to do and you don't know how you should pack it, you don't have anything to pack it with, covering it is better than doing nothing. Clean ABD pad. I want to tell you guys something about ABD pads because I'm not sure if everybody knows this. Did y'all know that on an ABD pad there's a blue line there? Do you know why that blue line is there? What'd you say? Correct. Do you know why there's a difference in the side? Why that's important for you to know? Right. So the blue side needs to be on the outside. This is the absorptive side. Okay? Can y'all see it? Y'all know what that looks like. So I'm going to tell y'all what I would use. Yeah, go ahead. Come on now. Yes, I love that. Yes, you're right. The wound looks a little, hand me that. Dirty, right? Also, no, the microphone. Sorry. The wound looks slimy, right? Also, like the tissue is kind of like red and it almost looks like it's a little bruised, right? So I know for sure that there's bacteria that's like having its way. I probably would use, if the wound is draining heavily, I would probably use a silver alginate rope, right, to pack in, like a long piece of rope, to pack in the undermining area. And then I would use the rest of it and fluff it into the other area that's not as deep. And then I would cover it with a foam. The foam, since there's silver in the alginate, I wouldn't then use a silver foam. That's unnecessary. Okay, it's too much. Don't do that. It's too much money. What you want to have the silver is whatever's in contact with the wound. Yeah.
So is a wound with undermining like that sort of almost like by default necessarily effective?
No, not necessarily, right? But the undermining, I feel like specifically in pressure ulcers, undermining, and a lot of times in other areas too, it tells you that there's shear. Does anybody know what shear is? Right? So like shear is like two opposing surfaces. The patient, if you think of a person that's bedbound, the patient's skin is going this way, but they're in the bed and their body is sitting up, but their skin and soft tissue is being like pulled in a different direction. And so it's damaging the tissue underneath. That's why you get undermining, okay? So if you do see undermining, I think this is probably like a pressure ulcer. If you do, that means you need to address friction and shear, which if it was another type of wound, that means you need to figure out where it is. So like for pressure ulcers, I feel like a lot of the times that's why it's important for the head of the bed not to be above 45 degrees. And for you to have a support surface that accounts for friction and shear. Good job, y'all. I'm doing something right up here. All right, when to refer, we talked about this yesterday. Probe into bone or a blood vessel, they need to go see someone else. And that's even for me. Like if I've been doing this for a long time, but if I'm probing to somebody's bone, I want to do testing to make sure there isn't any underlying osteo. If there's a vessel, no. In the outpatient setting, no, we're not. I need someone to check and make sure that things are on the up and up. Wound decline or no improvement after 2 to 4 weeks. This is a great option for, you guys were saying you have that e-consult service, right? So you've been doing it, you're using the topical care and thinking about all of those things and it's still not progressing. That's a great time to get someone else to like take a look at it and try to see what other options for treatment they suggest. Wound decline or no improvement after oral antibiotic therapy. You need to kind of do that. That's when like a wound culture might be appropriate. And like lower extremity wounds in people who have peripheral arterial disease and any wound on the foot, you need some extra support. Some kind of way possible, try to figure out how you can get that person some more blood supply. You just try your best. If they won't go to the appointments, I mean, I'm not saying don't treat them, but this is a time where you want to have some other people on board. Also, wounds on the feet, especially diabetic ulcers, podiatry is like so important. The wound itself needs to be debrided regularly. The hyperkeratotic skin around needs to be debrided repeatedly. So it's really important to kind of refer. Even people who have other like neuropathic ulcers from like, you know, a gunshot wound, whatever it is, you should, and it's on their foot, they need orthotics too. Okay, I see a couple hands. I saw you in yeah, go ahead.
So when you have undermining and the
Epibole, that's what that's called.
so at this point, every time I saw this in the hospital, we have to go in and like cut them after the undermining was fixed.
Correct.
So how are you managing that on the street?
So you can treat epibole, which, let me see. Come on, man. I'm just gonna, so this kind of looks like it might be rolled under. So in that instance, because remember I said wounds are gonna close because the epithelial cells are gonna connect, and once an epithelial cell touches an epithelial cells, like, all right, we're done. We're not doing anything. So what happens is the epithelial cells at the edge of the wound roll over and usually touch other epithelial cells. And so what do they think? We're done. And so that stalls the wound healing. So surgical debridement of the epibole to open the wound edges. Also, you can use silver nitrate to use them as well. And I have done that. I would say that it's definitely not as effective as sharp debridement, right? But I have used it. Somebody else in the back. Yeah. Straight back. Black with the black shirt, sweater, bun. Yeah.
So we have a lot of patients who don't make it in, either can't get into an appointment for podiatry or wound management, and we see a ton of foot wounds, and they're difficult to manage when we can't get them into
I agree.
podiatry. So just suggestions for
Yeah.
what we could do.
So, are you a nurse or a provider?
Provider.
Okay. So, especially if you're the primary care provider and you can figure out who in your area provides like orthotics that are for insurance coverage, you can order them. The process in our area is grueling. Yeah, it's so if you can't get them, some things that we have purchased that is like low level pressure relief for foot wounds, it's called a Pegasus, P-E-G, assist insole. And what it is like a foam insert, maybe about this thick. You can use them like kind of like you stack them to get a different thickness if you want. And then you take a little, they give you like a little red lipstick, and you outline the area of the wound, and then you take the Pegasus insole and you put it on the foot so that you can see where the red transfers to. Then there's little pegs in there, and you pluck out the pegs that are inside of the area that's red, and then you put it in a surgical shoe to provide relief of pressure to that area. The Pegasus insoles are maybe about, I don't know, I haven't looked in a long time, but maybe $50. Yeah. Yeah. Oh, I'm going to talk a little bit about that, okay? But remember, I'm trying to give y'all a framework for what to use for the wound. So you guys want to send them to podiatry, but the wound care, the topical care, is going to depend on the wound assessment, the amount of drainage, the amount of slough, right? Those things are not going to change because it's a diabetic ulcer. The debriding of the, I feel like Kara has done some debridement of like callus. So you can do some additional training to learn how to kind of shave that down a little bit. They can shave callus area, callus skin down with, what are they called, y'all?
Do like some, with like iodine and just like an 11 blade, I'll shave some of the hyperkeratotic tissue. It depends how controlled someone's diabetes. I normally don't mess with the people with diabetes, truth be told, unless it's like something to where they like can't function. I'm like very, very conservative with what I'm going to do. But for some of our other folks that just have like the callus is so bad that they can't walk, or like they have some kind of, then I will definitely like debride a callus, just like clean it with iodine. You could do like a really like thin shave with a 11 blade scalpel.
Somebody else? Yeah.
Quick question. So we used to have an NP that worked for our program that had some wound training and really advocated the use of like powdered collagen in wounds that are not infected. Is this a useful product for something like this? Mm-hmm. Do you have any thoughts about it?
Yeah, there are some dressings. I don't use powdered collagen, but I do use dressings that are like collagen-based dressings called, like one of them is, it's Prisma. So I have used Prisma, which is a collagen matrix dressing that also has silver in it to like add stuff inside. I did not do an exhaustive list of dressings, so I'm sure there's plenty of other dressings you all have heard of that are options, but we just didn't have a lot of time. And I feel like we have so much stuff. We still have a bunch of stuff to do, and we only have like 20 minutes. What's up?
This is just that, just so you know, like in all the wound care that we do, I'm using the same similar dressings like 80% of the time.
Yeah.
Like it's very rare that I'm like out there. Like I mentioned in Luxtra, I've used that twice. I've mentioned, like Hydrofera. I don't use it that much. We're using like the standard stuff. You don't need to be really fancy.
No, you don't. So I mean, I feel like a lot of that stuff too is going to come with more experience, and those advanced modalities are going to be used by like people a lot of times who are like, someone who's wound certified or in like a wound clinic. I don't want you guys to get caught up on the fancy stuff. You can close these with the things that I'm telling you guys about.
And no one's going to leave here being Lydia Williams, although every single one of us wants to be Lydia Williams. I'm so sorry, you're going to be much closer to Kara Cohen's, and it's so sad for you. But we can strive to be Lydia's, okay? But that's not what's happening today.
All right, so I think we talked about this, and then we have some xylazine stuff, but we also have some info about venous stasis ulcers and diabetic ulcers. So I'm going to take a poll. Does anybody want to still go into the xylazine stuff? Or would you like to hear maybe a little bit about the venous ulcers and diabetic ulcers? Yeah? All right, let's move it. I like to move it. Oh, the do no harm dressing, okay. That's a good one. This was one that people asked about, maggots, right? What do I do? So not uncommon in xylazine wounds. I'll just do this really quick. So wound myiasis, I guess that's how you say it, occurs when eggs are laid in decaying flesh or wounds or draining pus. So this is different than sterile maggots, right? We want to remove them because they're not sterile and they bring bacteria and infection. So if someone has maggots and they were not put there by someone who uses larval therapy, they need to come out. So I usually irrigate heavily with Dakin solution. Or saline. If you don't have Dakin, saline is fine. And like that's when the pressurized saline comes in so that you can really get them out of there. And then you cover with a dressing that's going to protect the wound from additional flies and then prevent the migration of whatever eggs that turn into maggots in the wound, prevent them from migrating to other parts of the body or the wound. Like if the wound is like really big, you want to try to contain them in that space, okay? This is a lot of self-management. Okay, venous ulcers. This is a good one because I feel like in our work, we see a lot of folks who have these. Wait a minute. She's giving away all my secrets. Here we go. We have a lot of people who have these large xylazine wounds, but they have underlying venous disease. And I want you guys to pay attention to some of the signs when we go through them, because if they have other wounds, even if it's not a xylazine wound, even if it's a wound that developed from cellulitis, if they have underlying venous disease, it is going to make the healing process a lot more complex, okay? So lower extremity venous disease affects 7 million people worldwide. It's a lot of people for this particular thing. 2 million people with venous disease will develop a venous leg ulcer. So 2 million of the 7. And then venous leg ulcers account for 80 to 90% of all leg ulcers. So you see an ulcer on someone's leg and they tell you, I don't know. It just, one day it came out of nowhere. I want you guys to be thinking like, does this person have venous insufficiency? Or, I want you to think about that. 80 to 90% of all leg wounds. Just keep it in your, subconscious there. So venous leg ulcer care is estimated to be $14 billion per year with an estimated mean direct cost to over $15,000 to just treat the ulcer. Okay, so it's really expensive care. So we want to try to prevent them from getting it. And I think I have a couple slides to talk about how to help that. So then we have lower extremity venous disease is made up of chronic venous disease, right? And then chronic venous insufficiency, and we'll talk about that a little bit. So venous hypertension is caused by ineffective emptying of the venous system, which leads to capillary bed congestion and extravasation of fluid and molecules in the surrounding tissue. All of the venous skin changes that you see are because of this. So this impaired venous return results in pathological changes in the superficial venous system and the microvascular system, such as hyperpigmentation, dermatitis, tissue fibrosis, and ulcers, okay? All right, we've seen this stuff before. You got somebody who's got spider veins, right? This is telling you spider veins, that's anybody who has some spider veins has some venous disease, all right? Very beginning, no big deal. Reticular varicose veins, these are the ones that are like, kind of skinny and they like fan out a little bit, as you can see. Then you have varicose veins that are much larger and like coming through. And then towards the end with the chronic venous insufficiency, you see that there's the varicose vein, but there's also that like really hyperpigmented skin change in the area, okay? And so here's a healthy vein. And usually in your healthy vein, the blood's going up, and that's a valve there. And when the blood goes through, it closes. So this blood can only go in the next direction because the valve is preventing it from falling back. You can see in the other one there that the valve is floppy, and so the blood flow is stagnant and it's flowing back. And if you see how the vessel is like expanding, that's because it has nowhere to go, because the blood is constantly flowing up, but then it can't go. So it's getting stuck there and it's congesting that area. And so if it can't go up, it's going out. So here's some risk factors: female sex, family history, like your grandmother had venous ulcers, spider veins, all of that stuff, that's common. Multiple pregnancies. Lucky for us, huh? Those of us who have children. Prolonged sitting or standing, right? So our folks who are sleeping outside, constantly on their feet, that automatically puts them at risk for venous disease. So venous thromboembolism, or a deep vein thrombosis, that damages a lot of times the inside of the vessel, and so damages the valve. And so if the valve is incompetent, then you can get some venous disease. So your folks who have DVTs, this is why history is really important, because you're seeing someone who has a xylazine wound. Maybe you notice the spider veins, maybe, but they tell you that they had a DVT. They tell you that they always have swelling towards the end of the day, or lots of swelling in the summer. Those are important things for you to know, because if you don't know that, you're just treating the wound itself, but you need to add some additional treatment in order to support the wound healing in someone who has venous disease. All right, so previous leg surgery that messes up your vasculature inside a lot of times, so you can get some venous insufficiency and damage to your veins from that. Over the age of 50, and also being obese. So you want to assess the risks, like we just talked about them, and the causes that could cause valvular or calf muscle pump function. Your calf muscle is a very important muscle in the venous disease. The majority of the blood flow that's going back up to your heart is done by your calf muscle. So thinking about people who are sitting in wheelchairs, who do not get up and are not active, their risk is there because, or who have, think about any neurologic disorders, maybe someone had a gunshot wound and they have an ineffective calf muscle pump. So like if they have a shuffling gait, right? If you're not using your calf muscle, that you're walking, the mechanics of mobility and ambulating are off, you can also have some venous insufficiency from that. So you need to assess for cardiovascular disease, peripheral arterial disease, and diabetes, and any other conditions that affect healing. Hope that's a good theme for y'all. We're always assessing the whole person and other things that can affect healing. We're going to assess for triggers. Cellulitis is a huge trigger for a large venous ulcer. Somebody had cellulitis, they went and they took antibiotics, and then all of a sudden the skin is tight, it's swollen, and it breaks open, and then they've had this wound for months and they don't understand why. Also, rapid changes in swelling. So someone who has uncontrolled congestive heart failure and, they're off their Lasix. I mean, who takes it? I feel like patients never take that stuff. And their legs just get really swollen, and all of a sudden their legs are weeping, draining. And then next thing you know, because their legs are weeping and draining, wet skin is more weak than dry skin, the wound breaks open. Or contact dermatitis. They use the wrong soap, their leg breaks down, it's itchy, it's red, and then next thing you know, a little small cut is there, and then it's into this fulminant like venous ulcer. So you want to assess for the symptoms, so aching legs, swelling, heaviness, tightness, dry itchy skin, pain, worsening with dependency, and improve with elevation. I'm going to go through this one, and then I'm going to stop for questions, and you guys will have the slides, and you can look at diabetic ulcers. And so here are some of the signs, and I do have some pictures, and then I think I have pictures of the wound too, so we'll just get to that. So here we got spider veins, we got varicose veins, which are the really like big ones you see there, and then I think if you look closely, like on the leg that would be on your right, on the side, you can see like the reticular veins there, right? You see somebody with this, they have lower extremity venous disease, okay? Yes, in an ideal world, you send them to see how incompetent their valves are, etc. But we already talked about this. It's hard to get people in for testing. They have venous disease. This one, other one up top is called atrophy blanche. It's not a great picture, but you see the wound is there. And then around it, the skin looks like hypopigmented a little bit, almost like a little white. That comes from all of those changes from the congested skin and how all of that congested fluid like breaks down your tissue and manifests on the surface. That like dark color you see in the next picture going down is hemosiderin staining, and that happens from the blood not being able to go up, going out into the extracellular fluid, and then the heme from the red blood cells breaking down and depositing in the skin. And then this bottom one down here, this is not a good picture, child. I don't know what this is. I'm not sure. But if you look at all of these 3 wounds here, they're all shallow, right? And this one on the bottom you can see is draining. Venous ulcers are usually shallow, they're very wet, and they're very painful, okay? Arterial ulcers, not as much. They don't have blood flow, so they can't feel. Antimicrobial absorbent dressings are important because, like I said, most of these wounds, they take a long time to heal. You'll kind of get to somebody who has a venous disease where there's it's a chronic wound, so you need to address the bacteria at the wound surface. And it needs to be absorbent because they're wet. So we're talking foams, alginates, and super absorbers like Inluxtra, which Kara talked about, Drawtex. There's other things on the market that also absorb a lot more moisture than foams and alginates. Can you believe it? And then compression is the mainstay. It is like the best treatment for venous ulcers. Like I already talked about before, the number one treatment for any wound is to treat the underlying cause. So anything you can do to treat the venous congestion and to support, they're usually in the leg. I don't think I said that. They're usually in the leg. They're usually medial malleolar, right? So inside ankle, if not inside, usually ankle area. They can be in other areas. They don't quite know why that is, but they usually are ankle wounds, inner or outer ankle, okay? So if you can add compression to increase the compression at the ankle to support the calf muscle pump that can get the blood flowing out of that area, the wound will close. And I mean, it's fast. I've had people come in to see me before. I started multi-layer compression wraps. The person's had the wound for 6 months. They come in and see me, and especially a small wound like the other ones we had, I see them twice that week to do compression and wound care. The next week is closed. Okay, so it works very well, and it's the mainstay. So ankle brachial index testing is necessary prior to adding compression. I know Hillary said that she went to a really great talk, I wasn't here for that, about like ultrasound, mobile ultrasound on the street, and I think that would be a great utilization to try to assess and make sure that someone doesn't have a DVT. But with putting on compression, you should also be assessing someone's vascular status. So to make sure they have good flow going down and you're not going to put it on too tight. They do have compression that can be used for people who do have arterial disease as long as it's not severe. So if I think like an ABI that's like 0.5 and up, you can use them. But you need to pay attention to that. Or pneumatic compression. They should be referred to the wound clinic, wound specialist vascular, because these are so challenging. And I'm going to stop. Here's patient education. And I'm going to take any additional questions because we have 5 minutes. And I want to be respectful of time.
I had 2 questions.
Yeah.
The first is, can you specify how exactly you do the multi-layer wrapping? And then the second is a more general question about dressing durability? Because I know that some of the reasons that people use things like Cohen is because a simple gauze wrap is just going to fall off for someone who's kind of a rough sleeper, and how you address that with your wound dressing.
So most multi-layer compression wraps do have Cohen or some top layer that is resistant to that. So that's when Cohen, when we talked about it, that's when Cohen is really appropriate, okay? You need the Cohen layer. The more layers you're adding in the multi-layer compression, which is why it's multi-layer, the more pressure you're able to create, the pressure gradient you're able to create going up the leg. There are some great videos on like YouTube of how to apply multi-layer compression like an Una's boot, which is like a paste bandage, almost kind of hardens up a little bit and is like a calf. It's 3 layers. It's the paste layer. It's a bulky gauze Curlex layer, and then there's the Cohen layer. So you can check out some videos on YouTube about that. Most importantly, with the Una's boot, you need to make sure it's like smooth because it's going to harden up. So if it's got wrinkles in it, it can cause some additional skin breakdown. Other multi-layer, the other ones, and that's not static compression. So the compression is not constant. The Una's boot provides compression when the person is mobile. So it's great for people who are mobile. It's not a good option for someone who's bedbound. You need something that's going to sustain the compression because they don't walk. So the Una's boot uses the calf muscle pump function to support. And there's also videos for those 4-layer wraps as well. And they all come with packages, but I do agree it is really good to look at a video because the 50% overlap wrapping and the figure 8 wrapping specifically takes practice. So that was a great question. Was there another one?
This was just one of the dressings, though, that I would say that I think it's out of, like, if we're just starting wound care, if people are coming here for wound care 101, like, this is one of the few dressings that I will ask Lyd to see the person before I start it. Like, I know how to do it and I can continue it, but I don't initiate that order, and I've been doing wound care for 12 years. So I think that it's a good thing to study up on. It's a good thing to watch the videos on. It's not a good thing to initiate it. When I talk about if you don't know what it does, don't do it. Don't do this one if you don't know what it does or you really are not like sure how to do it. Just learn more about it and know that it's out there and it's probably what the person needs.
Yeah, definitely get some training on it, and you want to watch a video, but you also want to try to get in contact with somebody who also has done it, because when you're wrapping, different layers require a different amount of tension that you pull, and that's the tricky part.
The second part of the question was just compression aside, dressing durability for other dressings.
Oh, yeah. So, I mean, I feel like the foams and like those other dressings, if I'm looking for a dressing that's going to be a little bit more durable and like, protected from the elements, I like foams a lot because they have that backing on them that don't allow things to kind of get in. And then I would just wrap like with gauze layers. I also tell people all the time, like a clean like sleeve. You can put that on there. I don't usually recommend things that are like plastic because I feel like that just ramps up like other skin maceration, fungal infections, etc. So yeah, I mean, I do recommend those things. But I mean, to be honest with you, depending on how much the wound is draining, I don't focus a ton on dressing durability because I don't want people to not look at it. I mean, I've had so many patients over the years. I had this one patient, I used to have him come twice a week for me to do, Kate knows him, Una's boots on him. And when I tell you, he used to drive me crazy because he would come and we would do it, and then he wouldn't come in for 4 weeks. And then he would stroll in there with that dressing on, and I would be like, you didn't take this dress, I told you. To the point where he would come in and he would be like gone for like 2 months, and he would be like, I messed up. I didn't take the dressing off. I'm like, nah! So I really try to focus on getting people to understand that I don't want you to change it every day, and if I can get you 2 or 3 days, that's great. But I don't focus too much on durability because the dressing needs to be changed,
This is sort of an ethical question. Do you have a threshold above where you say this person is so much a risk to themselves for loss of limb or death that you would consider invoking like an involuntary commitment?
Ooh, yes. Actually, Janelle and I have a mutual patient. Janelle's in the back there in the yellow. She works at Pathways up in Philly. And we have a mutual patient who has a venous leg ulcer. She's had it for years. And she had it for so long that she ended up becoming anemic because she was bleeding so much from the wound. She's not injecting in it or anything, but she doesn't keep it covered. She kind of picks it sometimes. And so she had so much blood loss just from the wound draining that her hemoglobin dropped. I want to say the other week it was like 4 or something like that. And Janelle really was like instrumental in like really encouraging her to at least get evaluated. But we did discuss with the psychiatrist what would need to be done for a medical 302, for sure. Yeah.
I think we're at time.
Yes.
So I'm going to close this out, but there's additional resources.